Sweet. Okay. Hi, everyone. So thank you so much for the introduction. So I'm a psychologist at the MCRI, and I also conduct neuropsych assessments through the Melbourne NF1 clinic. So I'll be speaking about the role of a neuropsych, obviously, in NF care. And I also want to speak a bit about some of the research that we're conducting through this clinic. Now, correct button. Yes. All right. So to begin, what exactly is neuropsychology? So neuropsychology is a specialized field of psychology that looks at the cognitive, emotional, and behavioral effects of different conditions that can affect brain functioning. This can be a wide range of things. It can include things like epilepsy, brain tumors, multiple sclerosis, head injury, as well as genetic conditions such as NF1. Our role is to provide assessment and recommendations for treatment for kids who have cognitive difficulties. And as Dina mentioned before, this can look like a wide range of things. It can be attention difficulties, issues with problem solving, planning and organization, reading and writing, other kinds of learning difficulties as well. So why might my child benefit from a neuropsych assessment? So as you've probably heard before, difficulties with cognition, learning, and behavior are actually the most common side effects or complications of NF1. I am speaking about NF1 today and not NF2, purely because we predominantly see NF1 in our clinic, and that's what I can most speak to. So as Dina mentioned as well, NF1 is highly variable across individuals. Not every child will experience cognitive or learning difficulties. And to make things more complex, the kind of difficulties that kids experience can vary very much from person to person. So that said, there are some common areas that tend to be more likely to be affected in people with NF. The most common one, of course, is attention. We know that around 40% of kids with NF do meet criteria for ADHD. And as many as 70% will have either ADHD or other attentional difficulties. And this includes attentional difficulties that don't meet criteria for ADHD, but can still cause impairment in daily life. We also see difficulties with things like executive function, and that's a bit of a woolly umbrella term that refers to higher level attentional skills, things like organization, planning, problem solving, the ability to inhibit or control your own behavior, and working memory. We sometimes see difficulties with visuoperceptual skills that can affect things like your ability to navigate through different environments. Speech and language is another area that Mia spoke to at length. Obviously, I won't go into that. And academic skills are another area that we often assess, and particularly NF, we can tend to see specific learning disorders. This can be in reading, writing, mathematics, or a combination of these. There's the end of my slide. And finally, we can see, as Dina mentioned as well, it can take the form of deficits in intellectual skills. So this may involve difficulties in particular areas. So an individual child might have reduced speed of thinking, or they might have a particular difficulty with working memory. On the other hand, we may see an overall reduction in intellectual skills where the child's performing a little bit below average, but there's no particular pattern of strengths and weaknesses coming out. So obviously, huge variation between individuals, and that's why individual assessment is so helpful. So what does an assessment actually look like? So very similar to what a pediatrician does in a way, as Dina explained it. So we collected developmental history. We ask you lots of questions about your child's early development, early milestones, their behavior at home, how they're traveling academically and their grades, as well as how they're doing socially. So we really want to look at all areas of functioning in the child's life. With your permission, we interview teachers and other allied health professionals that your child may see, such as speech therapists, to get additional information about how your child is going from the perspectives of other professionals, as well as how your child is in different environments. We'll often give you often quite lengthy questionnaires, which are helpful to be completed by either parents or teachers or, again, other allied health professionals. And these are useful because they ask questions in a very standardized way and give us quite clear information about how your child is performing, in different environments. Because it's very common for kids to show a certain pattern of challenges at home and then completely different challenges at school, for instance. After we collect all that information, we put it all together, collate it into a report, and this report will describe your child's strengths and weaknesses and provides recommendations for supporting any areas of difficulty that were identified. We also provide verbal feedback to parents to discuss the findings and recommendations and to discuss what's feasible and what's not, and to get a bit of back and forth feedback, I guess, to help prepare a plan. So what really is the purpose of neuropsych assessment? It's not just about getting a report. So we can, in younger children, we'll sometimes identify early language and fine motor difficulties. Obviously, we're not speech therapists and we're not occupational therapists, but we do do some screening tests that can help to identify these areas. And this allows us to refer children on to speech and language support or occupational therapy for that early intervention. We also can identify disorders such as intellectual disability or specific learning disorders. So an example is dyslexia, which is also known as a specific learning disorder in reading. Obviously, this is helpful for providing recommendations to support the child's learning needs, but providing these diagnoses can also open doors to funding and other educational supports, which often require a formal diagnosis to access, unfortunately. So we also screen and assess for a range of developmental difficulties such as ADHD, autism spectrum disorder, and mental health issues such as anxiety and depression, which can be more likely to occur in people with NF1. And then we can provide referral to appropriate services, whether that's clinical psychology, referral to a pediatrician if the child doesn't already have one, ASD assessment services who can provide that further evaluation, treatment, and support. In many cases, we also provide letters of evidence to support NDIS applications for support funding. This is an area that is very much a continuing work in progress. It was discussed earlier. It can be very, very hard to know what makes, gets one family funding and another not. So this is an area that we have a lot of continuing professional development on, and we'll be, I'm hoping to have a lovely chat with some members of the CTF to see how we can improve the way we write our letters of support in our neuropsychology clinic. Yes, and I guess the last thing I want to say about what makes neuropsych useful is that it's an optimal way to understand your child's cognitive strengths and weaknesses. As your parent or caregiver, obviously you would know your child very well and what their strengths and weaknesses are, but it provides, I guess, a different perspective. Dina gave the fantastic example of many parents express concerns that their child's memory isn't very good. And that can actually be a presentation of attention difficulties, for example. So it's helpful to be able to provide tailored recommendations to the specific child in order to support them at school and at home. So next I want to tell you a little bit about our neuropsych service at the Melbourne NF1 clinic at the RCH. So apologies to people who are not in Victoria. But for those of you who are, our team caters specifically to children and adolescents with NF who are experiencing any kind of developmental, cognitive, or learning difficulties. We are an assessment clinic only. This means that we provide individual assessments, comprehensive assessments, usually every 2 to 4 years, but it depends on need. We wouldn't see a child more frequently than every 2 years. And our main role is to provide recommendations for treatment and support. While we do liaise with schools to discuss ways to support children in the classroom, for example, we don't provide ongoing therapy or intervention. We can only provide recommendations and refer on to other services who can provide that ongoing care. So how do you get an assessment? Most of our referrals come from within the RCH NF1 clinic, so from our lovely neurologist, clinical geneticist, pediatrician, and it's also possible to self-refer if you're looking to participate in one of our research programs. And you can, of course, contact Hayley, Nat, or myself, but I also will talk a little bit more about that in a moment. So because I think our clinic is a little bit unusual in that we're all scientist practitioners in our group, to give you an overall picture of the kind of research we conduct through this NF clinic. So our stated vision is to provide children with NF the best start to life by helping them reach their full potential and maximize their quality of life. That's what drives our research, essentially. So we're lucky enough to work with a wide range of researchers and clinicians, many of whom you've heard speak today, and who are based both in Melbourne but also interstate. So many people from many different disciplines, from clinicians, lab-based researchers, just about anyone you can think of. So what informs our studies is essentially our arrow, which shows the steps in the journey from identifying a clinical problem to developing treatment options for it. So first we want to understand the clinical problem, whatever that may be. Then we want to find markers that allow us to identify the problem as early as possible. We all know that early identification is important for early intervention to provide the best possible outcome for our patients. Next, we want to know why the problem is occurring and what the biological, cognitive, or genetic processes are that are involved. And this allows us to identify treatments to address that problem, whether that's in the forms of therapies or drug discoveries, which are then evaluated through clinical trials, and that in turn, these results inform clinical care for patients with NF in our clinic, but also across Australia and overseas. So just a very quick overview. So our Neuropsych team is involved in a range of multidisciplinary studies investigating all sorts of different things in NF. I won't waffle on about all of them, but I will focus on a couple. And just to give you a quick rundown now. So we're looking at social skills and autism spectrum disorder. We're looking at sleep disturbance in NF. We're looking at auditory processing difficulties, which is our tap-in trial, which is just beginning, that I'll talk about in a bit more detail. Thanks to the pandemic and the lockdown restrictions that limited our ability to perform face-to-face cognitive assessments, we've been running a study investigating the reliability and acceptability of conducting these cognitive assessments over telehealth. What I'm really excited about this study is that our data so far has been very promising, to the point that we're actually introducing more of a hybrid model in our clinical care. So we still prioritize face-to-face assessments, but more and more we're having a follow-up telehealth assessment to provide additional testing, for example, and so on, just to get a bit more information and to reduce the amount of travel that parents have to go through to bring their child back for a second day of testing, for example. As has been mentioned by other speakers, there's the TINT trial running, which is looking at the MEK inhibitor trametinib, a medication for reducing the growth of plexiform neurofibromas in NF1. And we're looking at the impacts of that medication on cognition and attention and overall quality of life. And we're also running a clinical trial looking at the effectiveness of methylphenidate, Ritalin, in children with NF1 and ADHD. So the first, sorry about the picture, that's fine, the figures don't really matter here. So the first study I want to talk about is our tap-in trial. So a recent study, not that long ago now, conducted by our colleagues here in Melbourne, found that about 1 in 3 individuals with NF showed significant difficulties understanding speech when there is background noise. So this isn't a problem with hearing thresholds, so it's not something that's picked up on your bog standard screening hearing tests, but it comes out when you're in a situation, for example, if you're in a busy restaurant and you're struggling to hear the conversation of the person next to you, or a busy classroom where a child is having difficulty understanding what the teacher is saying. So we have tests for assessing this ability to discern speech from background noise. Beyond that, 1 in 4 of the participants in this trial also showed abnormalities in the white matter tracts of the brain, which are associated with hearing. So what this kind of suggests is that these abnormalities in the auditory tracts are causing some distortion to the neural information. So speech may sound perfectly normal in a quiet environment with no other distraction, but that ability to understand the speech drops when there's competing information. Why is this important? Because not being able to understand speech against background noise can impact a lot of other areas of functioning. And with kids, there's often background noise. This auditory difficulty can cause issues with early language development. It can affect the development of phonological skills, as Mia talked about earlier. Things like being able to hear the difference between a B sound and a P sound is very important to later learn what letters mean and the sounds that they represent. So it's essential for reading and writing. These auditory difficulties can affect the child's ability to take in information in the classroom or at home if there's noises in the environment, and can look like, it can contribute to attentional difficulties in the classroom. So even if the child doesn't actually have fundamental issues with attention, they may look like they do because they're just not able to understand what the teacher is saying unless it's quiet. And what's interesting about this list is that these are all areas that research tells us kids with NF are more likely to have difficulties with. So what can we actually do to help kids with these auditory difficulties? So that brings us to the Tap-In study. So we're running a trial testing a listening device that you can use at school to improve speech perception against background noise. It's very simple, it's non-invasive, very easy to use. It's essentially just an earpiece that the student wears, and this is linked to a microphone that the teacher wears or keeps near them up the front. And the device simply boosts the volume of the teacher's voice so that it's easier to hear against any other competing noise. So to evaluate the device, we're assessing the impact on a range of different areas, so the child's literacy skills, speech perception, other hearing skills, inattentive ADHD symptoms, which is the one I'm most interested in, as well as social functioning and overall quality of life. Does this device actually make life better for kids when they're in the classroom? And the results of the preliminary study, or our pilot study of 10 people, were quite promising. So the figure on the bottom right there, there's 10 white dots, and that shows, oh, wait, okay. Part of the graph isn't showing. That's fine. So that dotted line is the threshold for normal perception in noise. And the white dots are the 10 participants who all had significant difficulties discerning speech against background noise. The black dots is how they performed with this listening device. And about 60% of them showed improvements up to normal thresholds, which is pretty significant. And really, this result, I find, is quite exciting because there's no other treatment for these sorts of auditory difficulties. Oops. Keep going. All right. So the next study I want to talk about a bit is our study looking at social skills and autism spectrum disorder in NF. So we know that NF is associated with higher rates of autism, and in fact around 1 in 4 individuals with NF will be diagnosed with ASD. And actually many more than that show difficulties with social skills and communication that don't meet criteria for ASD. So the aim of our study, and we've been running it for several years now, is first to identify the occurrence rates of autism in kids with NF. We also want to look at the relationship between autism and other developmental challenges such as ADHD, learning difficulties, anxiety, and language skills. And finally, we want to gather data to help us design future treatment programs to treat these social and behavioral difficulties in kids with NF. So it's quite an extensive battery of testing that we do, but because much of our research tests overlap with the cognitive testing that we do anyway as part of our usual clinical assessments, it's quite easy for parents, if they do opt into a study, to just stay an extra half hour or so to complete these additional tasks. So what that study actually involves is the family attends one or sometimes multiple visits, which includes the cognitive assessment, including some additional measures looking at social cognition. This includes things like the ability to take another person's perspective and to anticipate what someone else is thinking. We also have additional parent questionnaires that ask about the child's social skills, communication skills, and screens for symptoms of autism spectrum disorder. If a child is identified as having social difficulties, based on those questionnaires, they're offered a play-based autism assessment, as well as an additional, quite lengthy interview, which is one of the gold standard tests for assessing autism symptoms. I should make it clear that while these autism assessments are done in a research context, it means that we aren't actually able to make a diagnosis because we don't have the full picture of the child that you would get in a multidisciplinary autism assessment. However, patients who participate in the ASD assessment receive a report which summarizes the results of these gold standard tests, and that report can then be taken to the child's pediatrician, who may decide to make the call that they have autism or not based on that pediatrician's other knowledge of the child. So there's some benefits to families. And finally, some participants aged 7 years and older will be invited to do some brain imaging. And we care about brain imaging because it helps us to understand some of the NF1-related features of brain development that may be related to risk of autism or other developmental difficulties. So we're really trying to understand a bit more about the variability within NF. Okay, that was good enough. So I'm sure you're all very familiar with what autism is at this point, but I'm briefly going to talk about what autism looks like in the general population, and from our research, how it looks different in kids with NF. So we know that around 1 to 2% of individuals in the general population will be diagnosed with autism. Males are 4 times as likely to be diagnosed than females, and there's a huge variation in symptoms from person to person. The core symptoms of autism spectrum disorder can be divided into 2 domains: social communication deficits, and this includes things like difficulties developing and maintaining friendships, trouble with social cues, not understanding nonverbal communication, difficulty maintaining eye contact, that sort of thing. The other domain is the restricted interests and repetitive behaviors. So this is things like sensory-seeking behaviors, repetitive motor movements, things like hand flapping or toe walking, and stimming behaviors, as well as things like having special interests. In terms of co-occurring conditions, in the general population, again, varies very much, but the ones we see most commonly are aggression, ADHD, language disorders, intellectual disability, and social anxiety. So, in children with NF and autism, we tend to actually see less clinical variation on the autism front. So prevalence, of course, is much higher, around 29% in NF, according to our study. And we've actually got a 1-to-1 male-female ratio. We don't see that 4-fold increase in males in our NF population. In terms of comorbidities, we still tend to see social anxiety, language disorders, and ADHD, but we're much less likely to see aggression, and we're much less likely to see intellectual disability in these patients. In terms of the actual autism, the core symptoms, in NF, we see a lot of the same social communication deficits as in non-NF ASD patients. So again, things like problems reading social cues and maintaining reciprocal conversation and eye contact. We also see some of the restricted interests and repetitive behaviors. So we tend to see things like insistence on sameness and difficulty adapting to changes in routine. But we don't really tend to see the repetitive motor movements. So things like the hand flapping, toe walking, stimming we're much less likely to see in kids with NF and autism. So what this means clinically is that it can be harder for professionals, especially those who aren't versed in NF1, to identify and diagnose ASD in kids with NF. This is because they may present in a more subtle way, and they may not show some of the more, I guess, prominent features of ASD that a lot of clinicians will be looking for. Oh, sorry, I'm down to 0 minutes.
Okay, yeah.
Sorry,
That's all right.
can I have 2 more minutes?
Speak to Renee.
Yeah, sorry. I was trying to speak slowly, but anyway, the last study I want to plug very briefly is our methylphenidate study. Basically, obviously already, kids with NF and ADHD are prescribed methylphenidate or Ritalin. It's very successful, but we're conducting a long-term clinical trial. It involves 6 weeks on methylphenidate versus 6 weeks of placebo. And we're looking at not only the impact on attention and ADHD symptoms, but we're also monitoring things like other cognitive domains, behavior, how they're performing academically, and overall quality of life. So it's quite a broad range of areas that we're looking at. We're also conducting functional MRI scans because we know that these attentional difficulties are accompanied by abnormal brain function. We want to see if the methylphenidate can actually reverse this abnormal brain function in kids with NF. And yeah, the last thing I want to say is a quick shameless plug to say we are always looking for participants who may be interested in taking part in our research. And we are so grateful to all of our families who've participated already. We're always looking for people with NF, 6 months of age or older. And for kids, we do need an English-speaking caregiver or family member who can complete some questionnaires for us, because we only have the English questionnaires. We're also looking for children from the general population who do not have NF to provide a control group for comparison. We're looking for kids aged 3 to 15 who don't have any genetic, developmental, or neurological disorders, and it can be a brother or sister of a child with NF. If you're interested, I've got a sign-up sheet out in the other room near the tip sheets. You can also come harass me if you see me around, and you can send us an email at nf1@mcri.edu.au. Thank you so much for all of your time today. And yeah, thank you.
Thank you. Thank you for that. I have a quick question. So for the studies, are you able to, is anybody that's outside of Melbourne or Victoria able to participate in those studies, if they can be done interstate in some way?
Sorry, is this on?
Yeah.
Yes, sweet. So we do have collaborators at the Westmead Hospital in Sydney, and so anyone in New South Wales is able to participate in many of those studies at our Sydney site.
But not outside of Sydney?
Outside of Sydney, probably not, unless they feel like travelling into Sydney or Melbourne, unfortunately.
Yeah, we do have a question on how do we join the studies. So we'll make sure that we share that email address and put more details on our website as well around how you can actually access those studies with Hayley directly as well. Similar to my question with Dina, would my 15-year-old about to turn 16 NF2 child benefit from a neuropsychology assessment who already has a diagnosed ASD and possible ADHD, especially as he is now entering a specific age in life, exactly senior level, is an ASD high school and Centrelink requirements? So he's got NF2 but also a diagnosed ASD and possible ADHD. Would he benefit from an assessment?
Okay, so I don't think I can quite answer that. It would depend on if this individual has been assessed in the past and has a previous cognitive assessment that would still be relevant. Mm-hmm. We actually don't see patients with NF2 in our clinic, so I'm afraid I can't comment on the specifics of that diagnosis, but I would recommend that that person get in touch with their clinician to ask if that would be relevant.
Okay. Is there anybody else in the room with a question? One over here.
A quick one on the tap-in program. Is it compatible with schools that have an existing hearing aid system and ones that have a audio reinforcement system? Would it be doing a similar thing?
I'm afraid I'm not familiar with those systems.
Cool.
I can follow that up and get back to you.
That's okay.
But I mean, it's a very simple device, so I don't see why it wouldn't be doing the same thing if those systems are simply boosting the voice of the teacher.
Any other questions? Oh, one down the front with Meredith.
Sorry, I understand why you need sort of Melbourne or Sydney-based people for the vast majority of these studies. I'm just wanting to clarify the tap-in one. Is that not something that could be done for people in other states?
So for that study, you do have to attend for a number of cognitive assessments. Whether it's possible to do that fully via telehealth, I'm not sure. That would have to be, I can ask the lead on that study if that's possible. My understanding is that we'd want to meet the person face-to-face at least once to show them how to use the device. But if there's a lot of interest outside of Melbourne and Sydney, I'm sure we'd be able to set up a protocol. If there is, okay, let me follow that up.
Well, if that becomes a possibility, we'll definitely let people know. But I think with that, we can probably wrap up the day. Thank you so much, Hayley.